Thank you very much. Hopefully you guys can hear me. I'll try to talk into the mic. I might wander around a little bit, but it's an honor to be here. When I was asked to do this last year, I said yes very quickly because this is a great organization and they do really great work, not only for our patients on a daily basis, but also for research and raising funds for a cancer that is an extremely important problem for our patients, for the public health, and does not get enough funding in the research field. It's one of these cancers where it runs the full spectrum from where things are fairly simple when you get into, as Ferg Devens had said, sort of an annual follow-up. You come in and get a scope done and you're cleared and you come back next year. It gets pretty simple on down to where we have our most complex surgeries and very difficult problems with advanced bladder cancer, and unfortunately we're still losing people who become friends to us over the years. We see them, we check their bladder, things get further along, and we lose people in this disease, and we really would like to stop that. So the best way to do that is research, and so this organization is helping tremendously. So my talk is really on the non-muscle invasive component of bladder cancer. I'll do a little quick intro into muscle invasive at the end. We think of bladder cancer in sort of separated into categories. So non-muscle invasive used to be called superficial bladder cancer. We don't use that term anymore because I think it really doesn't tell us how important and how potentially deadly some of these cancers are, even if they're just growing off the surface. And we have to be very careful with those. So superficial seemed that it wasn't really appropriate. So we've sort of broken it into non-muscle invasive, which can include some bad actors, and muscle invasive. And we'll take you through that. I think there is some bright light in the future for us, and in the near future, in fact. So you've heard some of these things. You can see some of the stats on the posters, but this is a common cancer. Sometimes people don't know what bladder cancer is. We do our walk. We walk around. People are kind of like sometimes looking at us. What's bladder cancer? What's a bladder? You know, what are you guys doing? So it's actually the fifth most common cancer in Canada. You can see new cases, 8,700 total. 2,300 people die every year in Canada from this disease. There is, based on those sort of silhouettes, the male is 6,600 new cases, female 2,100. So there is a bit of a discrepancy. Males tend to be affected a little more often. Overall, about 1 in 27 Canadians will be diagnosed with bladder cancer in their lifetime. These are fairly recent stats. So what is it? So basically, it's an abnormal growth of cells arising from the lining of the urinary bladder. I'm going to show you where that is in a sec. About 80%, between 70 and 80%. Do you need? Oh, thank you. Between 70 and 80% of patients that sort of come through our door that we diagnose with bladder cancer have the non-muscle invasive type that I'm talking about mostly. The others have muscle invasive or worse, metastatic bladder cancer. And you're going to hear about that a bit from Dr. Ong tonight. So conversely, 20% or so, maybe a little bit higher. Most of the non-muscle invasive cancers are very treatable, and we can prevent recurrences and we can prevent them from getting worse. And so we do I think a very good job with non-muscle invasive bladder cancer for the most part. So this is an anatomical slide here. I don't know if I can get the mouse to work up there. So you see the arrow coming down in men. The bladder sits here right in front of the rectum. Prostate is just underneath, and the urethra, urine channel, flows through the prostate. So it's just behind your pubic bone, lower abdomen. In women, very similar location. Different surrounding organs, obviously, sits right in front of the uterus and the vagina. And so bladder cancers that can arise here and extend elsewhere can extend into those surrounding organs potentially. So the main risk factor for this disease is smoking. So if you have bladder cancer and you quit, it makes a big difference. In fact, you quitting smoking is probably going to do more for your chance of recurrence than anything that we do medically. So you really have to quit. And if you're a smoker and don't have bladder cancer, quit anyway, because you're doing yourself a lot of harm. So there are a lot of other sort of risk factors. Some of these are kind of soft. We don't really get too worked up about a few of them, but Certainly, if you've been exposed to chemicals in your work, maybe worked in a factory for a few years, exposed to some chemicals in the days before there were a lot more safety standards, you might be at risk potentially. If you had prior radiation to the pelvis, you're at risk. So blood in the urine, that's the whole thing behind our campaign about seeing red and call your doctor. And that can be either you can see it, so you pee and you see red blood in the toilet or in the stream, or you go see your doctor and get a checkup once a year, and if they do a urine test, they might see it under the microscope, whereas you didn't see anything red at all. And both of those are important, and we need to see people with both of those conditions. People sometimes have urgency, frequency, some painful urination or burning. Those are often symptoms of urinary tract infection, but sometimes we see patients who have infections or the doctor thinks it's an infection, they give them antibiotics, and there's a delay to diagnosis. So be careful if you have an infection and it hasn't been documented as such. You may want to be sort of pushed to be referred on. We do imaging tests, so ultrasound or CAT scan is the reasonable first imaging test. If you pee blood, I know we're talking about bladder cancer, but it can be a kidney cancer or a type of bladder cancer that's up near the kidney that we're not going to see with just looking at the bladder alone. So we have to not just have the blinders on, we have to look at what we call the upper tract, so the kidney and the ureters. And we also do a cystoscopy. We do a urine check to make sure there's no infection present, and we can send the urine off for this thing called cytology, which looks for cancer cells in the urine specimens. So cystoscopy is pretty straightforward. I suspect a lot of people in this room are intimately familiar with this test. This is the cystoscope we use. It's actually fairly small. It's flexible. These are digital. There's a digital camera on the end of it and a light. We flow water through it, and we insert it in. This is a picture in a male. We insert it through the urethra into the bladder, and we fill the bladder with sterile water, and we can then look around the bladder and all the little nooks and crannies and see if there's anything abnormal, in particular bladder cancer. And we do these routinely for people who have a bladder cancer that is treated and they're at significant risk of it coming back. Sort of 50 to 80% of people will have their tumors come back over their lifetime or over the next 5 to 10 years. And so we put them on a program of repeat scopes because they may not have any other way to know that they have a recurrence. So these are a few pictures of some typical bladder tumors. They tend to grow off the surface the majority of the time, and they grow looking like raspberry or cauliflower, or some people say it looks like coral reef, because when we're putting the cystoscope in, the water flows and these things sort of wave around. And most of what you see in this picture are probably not really life-threatening tumors. These are tumors we can deal with fairly easily. And probably not invading into the muscle of the bladder. So for imaging, as mentioned before, we have to look at the kidneys as well. So CT scans, we rarely use MRIs and sometimes use ultrasounds. The purpose really, once we find a bladder cancer, of doing the imaging is to make sure that we know whether there's extension outside of the bladder, whether it has spread anywhere else, and if there's a sign of it, perhaps liver or other places in the body. So this is an example of a CT scan. I don't know if you can sort of figure this out, but this is kind of the tailbone back here, and these are the hips on either side. This is the left hip. Bladder's right here in the middle, and this sort of whitish, irregular growth that you see here is a bladder cancer that probably isn't a muscle-invasive cancer in this picture. But it does not appear to extend outside of the bladder. So once we find the bladder tumor or bladder cancer and we've put the person through the imaging to rule out spread, we then have to bring them in to remove the tumor, and this surgery is called a TURBT. Some people call it a TURBT. You can call it a scraping, whatever you want to call it. The TURBT stands for a transurethral resection of bladder tumor, so that's what a lot of you will have sort of consented to when you sign up for your surgery initially. We do this in the operating room. We use a scope, goes up through the urethra. It's usually an outpatient anesthetic. We can do it under general or a spinal anesthetic. Some people refer this to as a scraping, just an easier concept for them to deal with. And when we do it, we include a piece of the actual bladder wall. So we cut the tumor that you saw in those previous slides. It looks like a little cauliflower. And then we take a last bite into the muscle wall of the bladder to make sure there's no invasion into the muscle. That tissue goes to the pathologist for examination, and usually we get a report in about 3 to 4 weeks. So that's usually your first surgery if you're found to have a bladder cancer. This is the TURBT, kind of, I don't know if you can see the picture well, but this is a metal loop that goes around from side to side. We can work this piece of equipment through the scope back and forth, and we can move it up and down. And it has a very specific type of electrical current in it. And when you pull it back through the tumor, which you can see on the right side, sort of pulling that loop through, it cuts sort of like a hot knife through butter kind of thing. And you can see on this sort of the schematic in the lower right, this one comes on a little narrow stalk. Sometimes they have a broader base or they're more invasive looking. In this case, we'll take away the part that you can see, what we call the papillary or exophytic component, and then at the end we'll take that bite down into the bladder wall and send that along with the tumor to see if there's invasion. So that's really what we're doing when you talk about doing these scrapings or TURBTs. So key things that you need to, I think, understand as a patient who's diagnosed with bladder cancer, you need to know the grade and the stage. And these are really key. I'll try to explain these to you. So the grade is really when they take the tumor and they look under the microscope, the cells look different. Some of them look close to normal, and that would be low grade or grade 1. And some of them look really bizarre, very different from normal. And those are more aggressive tumors. They're called high grade. And that's important for you to know because it makes a huge difference. Grade 1 generally will not be a life-threatening tumor. Grade 3 potentially could become a life-threatening tumor. Stage simply means a fancy medical term for whether it invades or not and how far. So if it just grows off the lining of the bladder, doesn't invade, we call that a TA, sort of the earliest type. And also there's a flat tumor called carcinoma in situ is a term you might hear. Carcinoma in situ is a bit of a different animal. It has a higher grade but doesn't invade. But it can do some nasty things. In a small percentage, they can actually spread outside of the bladder without invading. More commonly, they'd invade deeper over time, so we really have to be careful with that. But it's a non-invasive high-grade tumor. TA is low-grade, just off the surface usually low-grade, always just off the surface. T1 means it invades into the next layer but not into muscle. So once you know your grade and your stage, you usually have a pretty good idea of how these things are going to behave. So this is another sort of schematic diagram. I'll try to take you through this. This mouse is a little sticky, but I've drawn a red line to divide non-muscle invasive toward me and muscle invasive away from the red line. You can see there is a surface lining of the bladder here. So we call that the mucosa. Just like the mucosa, the inside of your mouth, any of sort of the wet areas in your body. And this next layer is called the basement membrane or lamina propria. And then there's the muscle layer. Beyond that is the outside of the bladder, and this is basically fat. And on the other side of the fat are other organs like uterus or bowel. So if you look at these tumors that have been drawn in here, so carcinoma in situ is this sort of flat-looking tumor that's high-grade but not invasive. It's just growing off of that top mucosa. Then you have your TA, sort of raspberry kind of tumors that are just growing on the surface, not invading at all. You come down to T1, and the T1s are a little more potentially nasty tumors where they grow into the lamina propria, not into the muscle. So if you hear T1, you know that it's growing through the top layer into the next layer before muscle. And those, we treat them with great care because they can do some bad things. They sort of prove their activity already by send down these sort of roots into that next layer. So they're proving that they're bad actors. So now we have our stage and our grade, and now we have to kind of look at the tumors in two ways. This is sort of how we think in the cystoscopy room. So tumors that are just at risk of coming back, but not really at a high risk of growing deeper or spreading, are usually the low-grade ones and non-invasive. And the ones that are at risk of progression, so the term progression means that they can come back and they grow deeper, maybe get outside of the bladder or spread. And those ones tend to be the high grade, any high grade tumor, the CIS, which is that flat tumor I showed you, and the T1. If you have a T1 that's high grade, again, that is potentially a bad actor. The tumors that are at risk of recurrence usually do not threaten your life. Very rare for these to progress to a riskier form or a more aggressive form, but we do keep a close eye on people over time. Thank you. And these folks generally need frequent scrapings or TURBTs to control the tumor recurrences. We sometimes use a medication called mitomycin C, which is a chemotherapy drug, to prevent recurrences, and it can be put into the bladder in the operating room or after a TURBT or through another technique I'm going to talk about in a sec. And we do cystoscopies regularly. The ones that are at risk of progression, if left really untreated, many of these can become muscle invasive. If they become muscle invasive, then they can spread. We treat these with a drug called BCG to decrease the chance of progression. So the drugs like mitomycin and these other drugs just reduce the chance that it will come back, and drugs like BCG reduce the chance of them progressing on to worse tumors. So BCG is kind of a weird thing. It's actually the first immunotherapy ever approved for cancer treatment. We've been using it for decades now. It was actually discovered by a doctor in Kingston, Ontario. It's a weakened TB that you mix with water and we put into the bladder through a catheter. And we do it usually weekly for 6 weeks. And then we do long-term treatments for about 3 years in people that need that extra sort of booster treatment. The side effects are important. I was asked to maybe cover these quickly. Don't have a lot of time, so I don't want to spend much time on this. We can talk about it later. It just causes symptoms of a bladder infection that usually go away within about 24 hours in most cases. In some patients, because the catheter is going in, they get an actual bladder infection. They can have long-term bladder irritation from the BCG, and very serious sort of blood-borne BCG infections are extremely rare, fortunately. So we do all kinds of things to treat this. Time, we skip a dose, we try Tylenol, reassurance, maybe some antibiotics if we think it's an infection. We have some drugs that decrease bladder spasm. We can reduce the dose, we can stop the treatment, or in rare cases we have to give anti-TB drugs. So some new exciting technologies that actually I think are shortly coming to the Ottawa Hospital. One is a thing called EMDA, electromotive drug administration, which is a way of kind of pushing the mitomycin into the wall of the bladder. So this is the machine. It's pretty straightforward. It would be sitting in the clinic. If you're coming in for a bladder scraping that day or TURBT, we might do this earlier in the day. We don't have this machine yet, but we are sort of at the senior management level, but I'm assured that this is coming very soon. Basically, we put a catheter into the patient's bladder. They have these electrodes on their abdomen, and you put the drug into the bladder through the catheter, and then the current will push the mitomycin into the bladder wall, and it can help reduce recurrences. There's another technology that also I think is coming to the Ottawa Hospital. I'm quite confident it's coming. Basically, it's called blue light cystoscopy. So the regular cystoscopy that we use is called white light. And so you can sort of see here a bladder tumor with a little second bladder tumor sitting next to it. So that's what we would generally see. If you put a medication into the bladder and then look under a blue light, you might see other tumors around that you wouldn't necessarily have picked up just with your regular white light. So this can sometimes be very helpful in certain cases where we think we've eradicated the tumor and we're not sure, maybe that keeps coming back. You do it with the blue light and you can reduce recurrences nicely. Just going to jump through a little bit of this stuff. Okay, so that's really the end of non-muscle invasive. I have one more slide on that. Muscle invasive is the stuff on the far right of the slide, basically into the muscle or through the muscle outside. Treatment options, again, will be discussed tonight. Surgery to remove the bladder. We usually give chemo first, or a combination of chemo and radiation to treat the bladder and preserve it. So my general advice to patients who are diagnosed with bladder cancer. So ask questions. Don't be afraid to ask questions. Write down your questions and bring them in. Your doctor will not mind you sitting there with a pen and paper and asking off your list. They shouldn't mind. I don't know anybody that would mind hearing those questions. Bring somebody with you. It's often helpful to have somebody else hear the same thing you do. You can go home and you can talk about it again, and I think you'll retain way more information that way. Understand your grade and stage. You can ask for the reports. There are programs like at the Ottawa Hospital where you can get my chart, go onto your chart, and you can get all this information. Ask your doctor, am I at risk of progression? You may not really know what category you're in. You're not sure if you're just in the recurrence group or if you're in the progression group. And if you're in the progression group, then I think it's good to know that and ask questions as to whether you're getting the proper treatment to prevent further progression. Know your options, know the side effects, know the risks. I think we do a good job of telling people that most of the time. Report your side effects to the nurse or doctor. If you're coming in for a BCG, for example, if you had blood in your urine that morning, do not get your BCG put in. The only really bad complications of BCG that have really happened occur when somebody comes in who's bleeding, gets the BCG, and it's like an intravenous shot of BCG. So we just do not do it. If we know someone's bleeding in the clinic the morning that they come for the BCG, we cancel that treatment and reschedule. So make sure you report any side effects or symptoms. It's not necessarily the best thing to just keep putting off a major bladder surgery. Nobody really wants to necessarily go through a bladder removal surgery and end up with a bag or a neobladder. But in some cases, you're better off to do that earlier rather than later. Feel free to get a second opinion. Tammy mentioned that earlier. I fully agree. It's your right. Make sure you get a follow-up. Don't just rely on your doctor. The follow-ups are critical in this disease. So if you haven't heard from us in 6 months or whenever we told you to get your scope, call the office and make sure you book it. And that's my talk.